اوكي تمام، هأخر روبينار. حاضر. اوكي. Professor Yasser will join, I think, in 2 minutes, he said.
Okay, that's fine.
احمد سامعني يا احمد؟
مع حضرتك دكتور ياسر.
اهلا يا حبيبي، ازيك؟ اخبارك ايه؟
اهلا بحضرتك دكتور ياسر.
Professor Yasser, 2 minutes and we can start the webinar, if please.
Okay, no problem at all. Okay. مفيش اي مشاكل خالص. Okay.
You've started the webinar already, Dr. Yasser.
I started?
Yes.
Okay. Okay. The same what's happened before.
Yes, no problem.
I will introduce the class. Bismillah ar-Rahman ar-Rahim.
Okay.
Good evening, everybody. My name is Ahmed Mahran. I'm a professor of Obs and Gynae at Mini University in Egypt and a member of the Egyptian Representative Committee of the ERC-RCOG. And on behalf of the ARC, I would like to welcome all our prestigious speakers, fellows and members of the ERC-RCOG, our colleagues, obstetricians and gynecologists in the MENA region and all over the world. And we are delighted to meet all of you in this special event, being the first of a series of webinars joining the fellows and members in the MENA region. Our webinar today will focus on one of the common gynecological problems that we meet in everyday practice, Polycystic Ovarian Syndrome. It gives me great pleasure to introduce Professor Yasser Abu Talib, the chairman of the International Representative Committee of the ERC-RCOG in Egypt. He will give the welcome note and opening of this webinar. Professor Yasser Abu Talib is a professor of Obs and Gynae at Ain Shams University and Army College of Medicine in Egypt. He's a consultant in pelvic floor surgery and aesthetic gynecology in the MENA region. Professor Yasser.
Thank you to have this wonderful, nice presentation. So I would like to just welcome you all on board. So this is the second webinar that we are going to introduce now. It's related to discussion, a very important subject. It's polycystic ovarian syndrome and disease as well. To be honest, I discussed the situation with our colleagues, the International Representative Committee in the MENA region, and we decided actually to start a series of webinar in collaboration with each other. So this will be the first one. It will be between Egypt and 3 countries from the MENA region. And after a month, we are going to introduce another webinar discussing a very critical, important subject as well, which is endometriosis, which will include Egypt and the other 3 countries as well. So I hope that everyone get more information and mainly from the clinical side and to enjoy our presentation. Let's start our webinar. And we hope to enjoy. If you want to ask any question, let us know. And Dr. Ahmed is going to collect all the questions and the comments as well to improve our capability. Thank you very much and have a nice webinar. Ahmed.
Hello. Hello. Assalamu alaikum, everyone. Can you hear me?
Alaikum salam. Yes, sure.
Yes, we
Hi,
can.
I'm Dr. Amina Bhatt. I'm one of the consultant obstetric and gynecologists in Saudi Arabia and the chairperson for the ERC-RCOG in KSA. So it's my pleasure to introduce our first speaker, Dr. Majid Al-Hudhud, who is going to present a very interesting topic which we come across in our daily practice, which is Polycystic Ovarian Syndrome in adolescents. This is a very challenging subject for all of us who deals with the young people in our clinic, especially in the MENA region. So I'll just give you a bit of intro about the Dr. Majid Al-Hudhud. He's a consultant obstetric and gynecology and an IVF consultant in Saudi Arabia in a very busy private sector, Dr. Sulaiman Al-Habib. He's also the head of the department in the same hospital in obstetric and gynecology. Majid has a vast experience of dealing with adolescent and polycystic ovarian syndrome. He is a fellow of American College of Obstetric and Gynecology, fellow of Royal College of Obs and Gynae UK. He also has a fellowship in reproductive medicine and infertility from Imperial College London, UK. And Majid also had a laparoscopy diploma in operative gynecology. So the house is open for Majid. So he's going to do the presentation and Dr. Ahmed is going to keep an eye on the questions. If you have any questions, please put in the chat box. And end of his presentation, we will have 5 minutes answer Q&A session. So we'll try to answer your questions. Thank you.
Thank you, Dr. Amina. Thank you, ERC, MENA region as well for arranging this webinar. And thank you for having me today. And thank you for the audience to have this meeting on Friday. I hope we'll make it fruitful and informative in a brief way. So we're going to touch the base of the polycystic ovarian syndrome in adolescents. So no conflict of interest. Our objectives today is to discuss and focus on the adolescent recommendations from the international guideline published 2023. Probably you are all aware of the first international evidence-based guideline for the management of the polycystic ovarian syndrome back in 2018. Now, this is the second version, so gathered more information about the polycystic ovary syndrome in general, and now we're touching the base of the updates as well regarding the adolescents. We're also going to discuss the importance of avoiding misdiagnosis of delayed or under or overdiagnosed polycystic ovary syndrome in the adolescents, and also the evidence-based management to address the symptoms of the polycystic ovary in adolescents, and to expand on approaches to identify girls at risk of PCOS, but not yet diagnosed, including the need for future follow-up. So, as we mentioned, the 2023 International Polycystic Ovary Syndrome Guideline launched actually last August, almost a year ago, and has rich information. I would really encourage all of us to review it. Now, to reach the diagnosis, which is the most important thing, actually, we have to touch the base of the fact that polycystic ovary syndrome is a common endocrine condition affecting about 8 to 13% of women in reproductive age and probably 6 to 18% of adolescent girls. And I would say we are at the upper end of these percentages, probably some of the studies locally indicating that the PCOS is about 20 to 40% of the studies, some studies. And the definition of adolescence, according to the WHO, is the age between 10 and 19 years. Significant and critical changes in growth accompany this actually phase of life, including the development and puberty, with its own changes that probably interact with the polycystic ovarian syndrome signs and symptoms. So the international evidence-based guideline identified a gynecological age of less than or equal to 8 years post-menarche under the term of adolescence. So here is the difference between the adolescence according to the WHO and the international guideline. We need to bear this in mind when we touch the evidence. When it comes to the challenges, I would say these are opportunities as well, as to have the diagnosis in between the normal pubertal physiological changes, irregular cycles, etc., including the acne. So we're gonna explain those in a minute. The risk of underdiagnosis is again important. Delayed or poor prognosis, but poor diagnosis also important. Some of the patients actually suffer during their early reproductive age and marriage that being missed or undiagnosed until late in their fertility journey to find out that they have the polycystic ovary diagnosis missed during the puberty and during the adolescence period. The use of inconsistent, non-evidence-based approaches in the diagnosis and management of polycystic ovary syndrome among specialists is still there, unfortunately. I still consistently hear that FSH-LH ratio, blah, 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 so this patient is diagnosed as polycystic. And in fact, many years back, FSH-LH ratio is no longer part of the diagnosis. Yet until now, I hear about this. And finally, there is lack of robust evidence. We know that most of the evidence, unfortunately, until now is of low to moderate quality. However, we need to stick to consensus so we can end up with better management. Criteria required for the diagnosis, including two major things: irregular menstrual cycles and ovulatory dysfunction as one criteria. The other criteria for the diagnosis is hyperandrogenism. You diagnose it either by clinical and or biochemical. So you need irregular menstrual cycle, and we're gonna have the definition of the meaning of irregular menstrual cycle, plus hyperandrogenism, meaning the clinical diagnosis. So literally, there is no need for pelvic ultrasound in this criteria to label the patient as polycystic ovary syndrome. Definition of irregular menstrual cycle here, it depends on the stage after menarche. So less than 1 year post-menarche, the irregular menstrual cycles are normal pubertal transition, so it doesn't count as abnormal. And after the first year of menarche till the 3rd year of post-menarche, so anything between 21 and 45 days is normal. So if it is less than 3 weeks or more than 45 days, then this would be labeled as irregular menstrual cycle. This is very important thing. So 1st to 3rd year of post-menarche, anything between 21 and 45 days is normal. After 3rd year of menarche, you expect the period to be anything between 21 and 35 days, or at least 8 cycles per year. Anything less than 8 cycles per year, you consider this abnormal menstruation or irregular menstruation. And then you have one criteria for the diagnosis, less than 21 day, again, more frequent cycles, then again, this is irregular menstrual cycle. Or after 1 year post-menarche, if you have more than 90 days of any one cycle, then this would be considered as abnormal cycle. Primary amenorrhea should be diagnosed by the age of 15 years or more than 3 years post-thelarche, the breast development. So if we have more than 3 years and nothing happened, then that would be labeled as primary amenorrhea. So this is the most important thing for the diagnosis of amenorrhea or irregular menstrual cycles. The second part of the criteria is the biochemical or clinical hyperandrogenism. For the biochemical, the calculated free testosterone or free androgen index or bioavailable testosterone should be used. So that means we need high quality assays, sometimes like liquid chromatography, which is need mass spectrometry and extraction or chromatography immunoassays to be used for more accurate assessment of total or free testosterone. But this is not really available in most of our labs. So we need to use calculated free testosterone. We don't have the proper measures to use free testosterone in general labs. So you better calculate it and have the free androgen index instead. Now, the other parameters like dihydroepiandrosterone sulfate actually has limited addition to the diagnosis and management, unless you suspect something like adrenal tumor, you don't necessarily need it. And unless it is very high, then if it is mildly elevated, has little value to change your management. So could be considered if you have doubt about a tumor and the testosterone, free testosterone is normal. Then you move to the next step and adding the hydroepiandrosterone sulfate. And it is, as we said, more useful in excluding other causes of hyperandrogenism, like non-classical adrenal hyperplasia. Now, the most important part as well of the diagnosis is the clinical hyperandrogenism. Only severe acne and hirsutism are considered as clinical findings. So mild comedonal acne is common in adolescent girls, but moderate or severe, like more significant. So if it is significant, if it is severe acne, then that would be labeled as hyperandrogenism and probably would be enough, no need for biochemical testing to label the patient as hyperandrogenism. Okay, now here is the classification of acne. If it is severe, I would label it as clinical hyperandrogenism, but if it is mild or moderate, probably not. When it comes to hirsutism, again, I would strongly recommend familiarize ourselves with modified Ferman-Galloway score. Actually, the modified now including 9 regions. If we look at it, sorry, yeah, here we have 9 regions of the body, and each of the scores could be 0, where we don't have any hirsutism, up to 4, where significant virile hair ending. So we calculate those upper lips, chin, upper chest, lower abdomen, and pubic area, around the arms, upper arms, legs, upper back, and lower back. Those are the areas you calculate then, and you get to the score. Now, if it is more than 8, usually this is hirsutism. If it is more than 16, then it's severe hirsutism. Some areas like Far East, they have lower threshold for hirsutism because, generally speaking, they end up with minimal, actually, hirsutism. So the score maybe should be around 5. And the lower the threshold, you more increase the overdiagnosis of hirsutism. So we need to be careful, but I would say in our region, if you have the cutoff of 8 would be reasonable. Now, the clinicians shouldn't ignore the patient complaint. Sometimes it might have negative psychological impact. So again, you treat this hyperandrogenism, or you treat it as hyperandrogenism. Reported unwanted excess hair growth should be considered important regardless, as I said, of the apparent clinical severity. Don't ignore the patient complaint because, again, we're touching here the psychological impact of the polycystic ovary syndrome features. So pelvic ultrasound and its role in the polycystic ovary syndrome diagnosis in adolescents should not be used with a gynecological age of less than 8 years as part of the criteria to diagnose the polycystic ovary syndrome. Why? Because we have high incidence of multifollicular ovaries in this life stage. There is ongoing growing, or like a growth of the follicles, overactivity, so mimicking the appearance of the polycystic ovary. And other polycystic ovary criteria have been derived from transabdominal, derived from transvaginal ultrasound, actually, which should be avoided in females not yet sexually active. So again, if the patient is possible to do the vaginal ultrasound, then we use the antral follicle count. We tend to say more than 20 follicles to label that ovary as polycystic. If we're using abdominal scan, we tend to use the volume as long as there is no growing follicle or dominant follicle. However, pelvic ultrasound, I'm not saying like don't use the ultrasound. We need to use the ultrasound to exclude ovarian tumors, abnormalities, uterine malformation, but not as a criteria to diagnose the polycystic ovary. You know, polycystic ovary diagnosis also has to rule out other disorders like TSH for the thyroid irregularity, etc., etc. Now, some people started to use the AMH. In fact, AMH as yet could be used to define polycystic in adults. Now they made the cutoff of 5.8 nanogram. However, still shouldn't be used as a single test for the diagnosis of polycystic ovary syndrome and shouldn't be yet to be used in adolescents. We're still gathering more data. But anyway, AMH usually climbing up with age, reaching the plateau around the 20 to 25 years of age, then stabilize. So it may be too early to label the patient, but using or like diagnosing her by AMH only or using it as a criteria. So exclusion of other conditions, as we mentioned, is very important part of the diagnosis. We need to rule out pregnancy, gonadotrophin deficiency. So here is the rule maybe of the FSH, LH, etc., estradiol, to rule out hypogonadotrophic hypogonadism or hypergonadotrophic hypergonadism. So these kind of things, as we mentioned, hypothyroidism, etc. Non-classical congenital adrenal hyperplasia, if you have this in mind, you do the 17-hydroxyprogesterone, and bear in mind that should be early morning at the follicular phase in the first 8 days of the menstrual cycle, around 8 o'clock in the morning, to get more accurate results. You need also to bear in mind Cushing syndrome and rule it out. And here we have the workup, as we mentioned, TSH, prolactin, gonadotrophins, androgens, plus minus follicular phase 17-hydroxyprogesterone. Those are important to rule out other cases, other like diagnoses. However, they are not part of the criteria to label the patient as polycystic. Now, the most important thing is not to forget the patient at risk of polycystic ovary syndrome. And why is that? This is the group in order to evaluate whether they will develop polycystic ovary near the adult stage. And here we have the recommendation that adolescents who were features of polycystic but don't meet the diagnostic criteria yet should have reassessment at or before full reproductive maturity at, like as we mentioned, 8 years post-menarche or 3 years post-menarche in relation to menstrual cycle irregularity, as we mentioned.
Majid, just to let you know, there's 3 minutes behind,
Yes.
4 minutes behind. Thank you.
Yeah, okay, thank you very much. So girls at risk who are the girls with persisting polycystic ovary or significant weight gain in adolescence, again, we need to bear this in mind. So polycystic cannot be diagnosed during adolescence unless both, as we mentioned, irregular menstrual cycle and hyperandrogenism are present. Now, emotional well-being is very important. You need to screen all adolescents routinely for this and actually give them the necessary support. Overdiagnosis of psychological conditions should be also avoided. So you need to be vigilant with this. Lifestyle changes is strongly recommended, especially disordered eating, as it has been noticed that this increased in polycystic ovary syndrome. Now, treatment options rely on 2 major things beside the lifestyle changes. Pharmacological principles of the treatment, individualized based on the personal characteristics, and we're probably talking about the OCPs or metformin. OCPs alone should be considered in adolescents with a clear polycystic ovary syndrome diagnosis, or could be considered in at-risk group. No specific type or to use or specific dose. You can use any, and in fact, the current actually recommendation state that 35 microgram ethinyl estradiol plus cyproterone acetate should be considered as a second-line therapy. To combine with metformin, fine if the BMI is more than 25, or if you're not getting the desired actually symptom control by pills alone, can be added. Metformin alone may be considered if high BMI, but don't exceed 2 grams in adolescents. Anti-androgens, the recommendation, pills for 6 months, no response, you add one of them. Bear in mind the liver toxicity of thalidomide and finasteride. Spironolactone sounds to be more like safety profile. Anti-obesity medication, anisotol, finally, they may be used in adults. It is safe in adolescents, but there is no data about the polycystic ovary syndrome patients, so we're still lacking data. Inositol, again, sounds to be safe somehow, but we don't have specific types, doses, or combination of inositol in polycystic, and especially in adolescents at the moment. The last is the model of care of patients. at the end, as we mentioned, you have to the transition to adult care is required for adolescents with a clear diagnosis of polycystic for future management of her contraception or fertility desire at the end. Thank you very much.
Hi, thank you so much, Majid, for a very informative presentation today. And I think all of us have, got some information out of it, very important information. And I hope that helps to clear everybody's concept or, about the polycystic ovarian syndrome, especially, the age of menarche and irregular cycles and what tests we need to offer. I think Dr. Ahmed has been collecting all the answers. So the questions, sorry. So we've got 5 minutes to answer those questions. So Dr. Ahmed.
Thank you very much, Dr. Majid, for this comprehensive presentation. I have actually some questions. The first is about the diagnostic criteria of PCOS in adolescents. So the question is, ultrasound, picture, and hyperandrogenism alone are not enough for diagnosis, as we excluded the ultrasound criterion in this age. What do you think?
Yes, it is very clear. I mean, ultrasound features, polycystic could be normal feature on the ultrasound. That's why you might get confused for that reason. And again, we don't use the transabdominal scan to count follicles. You only rely on volume. Ultrasound, as I said, is still important to rule out androgen producing tumor, ovarian tumor, etc. But at the same time, it's not part of the criteria for the adolescent in the first 8 years post-menarche.
Okay. The second question is about what is the cutoff level for free androgen index for diagnosis of PCOS?
Yeah, what are the cutoff value?
Yes.
Well, it depends on the lab. You need to check with your own lab. They calculate the total, actually, testosterone and the free testosterone, and they give you the free androgen index. And as I said, you will find it in each different lab separately.
Third question is about what is the effect of diet control on PCOS?
Yeah, it is very important question. Yes, it has a rule. Losing weight is very essential, actually reducing, because we know that there is 60% of the patient have insulin resistance, and this insulin resistance actually spare the liver and the ovaries. So you have high insulin, it will not improve utilization of blood sugar, except in the insulin actually will affect the liver and affect the ovaries. Hence, at the liver will reduce the sex hormone binding globulin, and at the ovary level will increase the androgens and LH, causing the symptoms. So simply, if you reduce the trigger of the insulin by low insulin, triggering diet, low carbohydrate diet, let's say, definitely you lower the LH and the suppression of sex hormone binding globulin.
Another question that is sabitron acetate for long time can affect fertility of girls treated for hirsutism?
Good question. Very simple. No, it doesn't affect the fertility. The thing is, it is a strong, potent anti-androgen, has very nice results with it. But, at some point also has liver toxicity. So, or, hemangioma sometimes could be happening as side effect. So you need to bear in mind the recommendation not to exceed the 10 milligram limit, and also don't use it unless there is significant side effect of the alternative like the pills, etc., or no benefit of the pills after 6 months of use. Otherwise, it is teratogenic, so we don't recommend using it in a married patient or without any contraception. So usually we use it in combination with the pills.
Okay. Next question is, what is the preferred test for insulin resistance in this age?
It is oral glycemic test. I think it is very simple thing to do, oral glucose tolerance test. Home test, again, you can do, but I mean, very simple oral glucose test is enough.
And the other question is, can metformin be given for slim patients with severe PCO?
Yeah, again, yes. But there is like 40% patient with lean patient with polycystic ovary syndrome who have insulin resistance. If the feature suggesting insulin resistance, then there is no harm of using the metformin. Although the side effects might be more than what we expect, and at the same time, pills are really good alternative in this patient. So I would be reluctant to use the metformin as first line.
The last questions, I think it's actually for myself. Do you think that care for these adolescents with polycystic ovarian syndrome needs dedicated clinics with input from dietitians and dermatologists rather than to be managed by gynecologists alone?
Thank you very much. This is what I'm trying to do actually at my local hospital. This is very clear idea and nice idea. It started actually to spread worldwide. I'm trying to make a dedicated polycystic ovary syndrome clinic, especially in this age group. You need the help of pediatric endocrinologists. You need the help of the dietitian, sometimes the psychiatrist and dermatologist. I think multidisciplinary approach is very, very important to achieve better outcome of those cases.
Thank you very much, Dr. Majid. I think we have to move to the next speaker. Thank you very much for this wonderful presentation and answering our questions. Thank you.
Thank you.
It gave me great pleasure to introduce the next speaker, Dr. Rasha El-Sheikh. She is a distinguished consultant, obstetrician, and gynecologist with 23 years of extensive experience in Sudan, UK, and Qatar. She obtained her clinical MD from Sudan Medical Specialization Board, diploma in medical education from Nottingham University in UK. Additionally, she has completed advanced training modules from ERC-RCOG in advanced labor ward and gynecological oncology. She held senior positions such as consultant obstetrician and gynecologist at Hamad Medical Corporation, attending physician at Cedra Medical and Research Center, and consultant at University Hospital of Leicester. She has special interests including medical education, minimal invasive and open gynecological surgery. Dr. Rasha will address the risk factors, manifestations, and impact on life in adult polycystic ovarian syndrome. Professor Rasha.
Professor Rasha, would you please unmute yourself?
Hi, Rasha, we can't hear you. Rasha, we can't hear you.
Yeah, can you hear me now?
Yeah, that's better.
Good. So thank you very much, Dr. Ahmed, for the introduction. And I'm going to be talking about the polycystic ovarian syndrome in adults. And as Dr. Majid mentioned, a lot of things from the guidelines from the Committee for the International Guidelines for Polycystic Ovarian Syndrome, which is designed in 2018, and this is the most recent one, was last year in 2023. And it's a combination of engagement of over 3,000 health professionals and a work of 100+ multidisciplinary clinical and lived experience experts from 6 continents and 21 countries internationally. And based on this, they do have recommendations. Some of them are evidence-based recommendations. Some of them are consensus recommendations. And the last ones were the practice point where there's no good evidence to support the recommendation. We try not to repeat what Dr. Majid already said, so we have to go quicker over what's already been said and introduced. And as we know, it's one of the most common metabolic and reproductive disorder among women of productive age. And it is associated with menstrual dysfunction, androgen excess, which significantly impact the quality of life. It's a diagnosis of exclusion, as Dr. Mard said. So we have to look when a patient comes with menstrual irregularities or hyperandrogenism, to look for other causes like thyroid disease, where we check the TSH, or hyperprolactinemia, we have to check prolactin, or non-classic congenital adrenal hyperplasia, where we have to check the 17-hydroxyprogesterone. This is, again, just a summary about the abnormalities and which lead to the metabolic, reproductive features, and clinical features in polycystic ovarian syndrome. For the diagnostic criteria, we've started with the National Institute of Health criteria. There were only 2 of them, which is hyperandrogenism and menstrual irregularities. And then the androgen excess PCOS society criteria, there were 2. But the one that we are all relying on now are the Rotterdam criteria, which is 2 out of the 3 to diagnose polycystic ovarian syndromes in adults, which is hyperandrogenism, menstrual irregularities, polycystic ovaries on ultrasonography, and recently we've added AMH, which can replace the ultrasonographic features. And there's 4 types of polycystic ovarian syndromes in adults. 1, which contain the 3 components of the criteria: irregular ovulation, hyperandrogenism, and polycystic ovaries. B will contain only the menstrual problems and the hyperandrogenism. C is hyperandrogenism with polycystic ovaries on the ultrasounds. And the last one is irregularity with polycystic ovaries. The categories of the guidelines recommendation, you're going to see this through the outline, through the presentation, that we have to mention any statement. Was it evidence-based recommendation, where there's significant and sufficient evidence to inform us about the recommendation, or was it a consensus recommendation done by the guideline team, or is it just a practice point where there's no evidence, but it has been made by the guidelines development group with important issues after discussion? I will mainly focus on the evidence-based recommendation on this presentation with few of the consensus recommendation. Polycystic ovarian syndrome, as we said, it's not only to do with the menstrual disorders or what we are familiar with in gynecology clinic. It's also associated with multiple other morbidities like obesity, insulin resistance, type 2 diabetes, cardiovascular, infertility, cancer, and psychological disorders. For the biochemical changes, we have to talk about what kind of abnormalities we have. As we say, it's not just the ovary. Maybe the problem starts from the ovary, but we have to add all the other metabolic problems that happen and produce at the end all the presentation and manifestations of the syndrome. We tend to have low progesterone levels, increased estrogen level, high level of autoantibodies, hyperandrogenism, dysregulation of glucose and fatty acid metabolism, insulin resistance, increased testosterone, increased fatty acids, and inhibition of T and B cells. As you can see in the normal cycles, we have the ovulation with the surge of the LH. And if you compare that with polycystic ovarian syndrome cycles, we have a plateau and straight line of the LH and FSH. And that's why, as Dr. Majid said, that we're not relying on the surge of the LHS or the ratio in between them to diagnose, because we know that it has very little correlation with the clinical manifestations and an impact on the quality of life. Healthcare professionals should use the total and free testosterone, as again been mentioned, because now we're not any longer relying on the FSH-LH ratio. And we use it for the diagnosis if we can have the free testosterone or the free testosterone index if it's not available. And as he said, it's very difficult, and we're trying now to introduce it to many of the labs to increase the sensitivity and specificity and to diagnose the polycystic ovarian syndrome. If testosterone or free testosterone is not elevated, healthcare professionals should consider measuring considering other problems, again, not to focus on the polycystic ovarian syndrome, and forget about the other rare congenital adrenal hyperplasia or the other metabolic disorders. For the morphology of the ovaries, as we said, in the past, we used to have reports say a lot of cysts at the periphery of the ovary, very non-specific with dense stroma, sometimes if they're generous to give us description of the stroma, to say it looks like polycystic ovarian syndrome. However, the committee tried to make a guidelines to make it very specific for the diagnosis, and stated that it's very sensitive. Follicular number per ovary should be considered as the most effective ultrasound marker to detect polycystic ovarian morphology in adults. So unlike in adolescents, we do rely here on the morphology of the ovaries, and we need to count them. And as Dr. Majid mentioned, we need a very good ultrasound machines and internal. It has to be transvaginal, and we have to count. For if we have less facilities or it's an abdominal ultrasound, at least we would like to see the follicular numbers per cross-section and the ovarian volume. The morphology criteria should be based on follicle excess and or ovarian enlargement, and that's only consensus recommendation. Follicle numbers per ovary, they have to be 20 or more in at least one ovary to be considered as a polycystic ovary in adults. And if we don't have the facility for good ultrasounds or transvaginals, then we'll do the volume should be more than 10 mils, and the count should be more or equal to 10 follicles in one ovary. The anti-Mullerian hormone, as being said, is being introduced recently to assist and facilitate the diagnosis, especially if there is no ultrasonography features clear on that patient. So it's can be used in defining the morphology in adults. Serum AMH should only be used in accordance with the diagnostic algorithm, noting that the patient who had irregular menstrual cycles and hyperandrogenism, they do not necessarily need the polycystic, because as the Rotterdam criteria, we already have two, and we don't need to look for the third. So we recommend that it should not be used as a single test for the diagnosis, and we should not combine it. We have not to do it in adolescents, and we should not combine it with the ultrasound as well to prevent overdiagnosis of the polycystic ovarian syndrome. For the clinical hyperandrogenism, the presence of hirsutism alone should be considered predictive of biochemical hyperandrogenism and PCOS in adults. So any patient with hirsutism, she should be considered. This is one of the predictive the biochemical hyperandrogenism. And we should recognize the female pattern, which I'm going to show in the next slide. So even the female pattern hair loss and acne in isolation without hirsutism may are relatively weak predictors of biochemical hyperandrogenism. So the most important one is hirsutism. We need a comprehensive history and physical examination, as being mentioned, and we should be aware of the potential negative psychological impact of this signs and symptoms of hyperandrogenism on the patient and the quality of life. This is where we can see the male. The first one is the female pattern of hair loss, and the second one is the male hair loss. So we are concentrating on the first one, hirsutism and acne. And we have to remember acne does not only present on the face. We'll ask the patient about other part of her body, and that should be included in the examination as well. Polycystic ovarian syndrome, it does carries increased risk of cardiovascular disease. And that's evidence-based recommendation that any woman with polycystic ovarian syndrome should be considered risk of cardiovascular disease and potentially of cardiovascular mortality, acknowledging that the overall the cardiovascular disease in premenopausal ladies is relatively lower than men. And again, it's an evidence-based recommendation that all women with polycystic ovarian syndrome should be assessed for cardiovascular disease risk factor. And all women with polycystic ovarian syndrome, regardless of their age, they should have lipid profile. So that's something that we should include when we request investigations for any patient with polycystic ovary syndrome. So at the time of the diagnosis, we request a lipid profile. And thereafter, the frequency of repeating that depends on the result that we got from the first time. Cardiovascular disease general population guidelines consider inclusion. So there is an evidence-based recommendation to include polycystic ovarian syndrome as an independent risk factor for cardiovascular disease, especially in women. And it's an evidence-based then that we should be aware that the women with PCOS have significantly higher prevalence of obstructive sleep apnea compared to other women. And these are the things that we should ask and actively look for during the clinical assessment of the patient in clinic. Women with PCOS should be assessed for the sleep apnea, a history of snoring, and unrefreshable sleep, daytime sleepiness, or fatigue. The most common thing that was always been associated with polycystic ovaries, and we tend to stress on it more than other risk factors, is the impaired glucose test and the type 2 diabetes. Healthcare professionals should be, regardless of the age of the BMI of the patient, they should know that a patient with polycystic ovarian syndrome normally at high risk of having an impaired fasting glucose and an impaired glucose tolerance test and type 2 diabetes. Glycemic status should be assessed at the time of the diagnosis. And a consensus recommendation is glycemic status should be reassessed every year to 3 years on additional individual risk factors for diabetes. So we have to inform the lady that she needs to keep an eye and follow it up. Endometrial hyperplasia and cancer, we know all that polycystic ovarian syndrome, because of the unopposed estrogen, there are higher risk of having endometrial hyperplasia. And however, because of the risk is very small in the premenopausal ladies, there is no recommendation for a routine screening for the endometrial screening. Healthcare professionals should be aware that because it's premenopausal women with PCOS have highly developing, there's high risk of developing endometrial hyperplasia, endometrial cancer. And they should be informed that the risk is relatively low, and that's why screening is not recommended. Eating disorders and disordered eating. Disordered eating is just part of the spectrum before getting into eating disorders. So any strict diet or compulsive dieting, again, will be considered as disordered eating because of the stigma of the weight that's always associated with polycystic ovarian syndrome. So we need to keep an eye on this. And as they mentioned before, that the best approach is a multidisciplinary team that should include a dietitian to look at that aspect of the problem.
Hi, Rosha. Just to let you know, there's 3 minutes behind, left. Thank you.
Okay. Depression and anxiety, again, these are the things that we need to stress on. And we have to remind the patient that it's a lifelong disease, enduring disease. So once you have polycystic ovarian syndrome, it will continue. And we do have manifestations of biochemical hyperandrogenism that persists up to the age of the menopause. Risk of relatives, there is professions that can be considered like fathers and brothers of women with PCOS. They have increased prevalence of metabolic syndrome, type 2 diabetes, and hypertension. We're just going to touch on the management for the non-fertility aspect because that's going to be covered by Dr. Saad. The combined oral contraceptive pills, as being mentioned, that should be the first line, and there is no any evidence to support using low dose or high dose of ethinyl estradiol, so 30 microgram or higher. There was no evidence to support either like benefit over the others. We just go with the general guidelines for using contraceptives. Progesterone only contraception, they may be considered if there is poor compliance with the estrogen aspect or there's contraindication, and it's used for endometrial protection. Metformin is being recommended as evidence-based. BMIs of 25 or more, they should start on metformin because it's superior to the combined pills. And it has limited evidence when the BMI is less than 25. We sometimes use them together most of the time, and they should be used if it's a problem is mainly hirsutism and menstrual irregularities. Combined contraceptive pills are superior to the metformin, Metformin is when there is metabolic and issues more than the hirsutism and the menstrual periods, and the combination of both of them again can be used. We spoke about the anti-obesity pharmacological agents, like what we use now, the Ozempic or the semaglutide injections. There is a consensus recommendation that they can be recommended for patients with polycystic ovarian syndrome. And again, because we have limited data about their safety during pregnancy, we should advise the patient to have contraception during the time of using them. Anti-androgens, again, being mentioned. But normally we use them unless there is no response from the combined pills or the cosmetic therapy, then we can go for these, and we have to keep in mind their complications and risks. These are the mechanical lasers. Bariatric surgery, again, is being consensus recommendation that we can use the surgery, bariatric surgery, to help especially those who are struggling with weight loss. And I think we just try to rush through it and not repeat what's already been said. Thank you very much.
Thank you very much, Dr. Rasha, for this very informative presentation. And I think Dr. Amina has gathered some questions for you. Dr. Amina.
Hi. Thank you so much, Rasha, for the very nice presentation. I think we do have some important questions people have asked. So one of the questions is they said, do we need to do the insulin resistant and HOMA-IR test for as a part of investigation for diagnosis of PCOS? Because I've seen in clinical practice, people are using these tests. So is there any evidence base to use this test for the diagnosis of PCOS?
It is recommended, yes, of course. It's recommended that we have to do, and the most preferable is the oral GTT. So we do recommend that we do screening for diabetes at the time of the diagnosis or at the time of first exposure with the symptoms. And then the follow-up depends on the results that we get. But it is very important part of the investigations.
Okay. My question, just to clarify, Rasha, so this test is a part of diagnosing the PCOS, or as in terms of once you've diagnosed, you're going to do all the lipid profile and screening as a part of screening? That is the question, whether you use it as a diagnostic criteria.
Yes. So once you've got your diagnostic criteria, you look for the risk factors that and the metabolic disorders that can happen with the polycystic ovarian syndrome, and then you start screening for them with the lipid profile, GTT, and the rest of the investigations.
Yeah, thank you so much. That's very clear. So again, they ask a question about any cutoff point for endometrial thickness for PCOS in order for further investigation for endometrial cancer.
We tend to say that in menstruating ladies, it's very non-specific, has very low specificity, unless we have other risk factors. So if you have somebody who is diabetic hypertensive with polycystic ovarian syndrome and you do a scan and there is not just a cystic changes on this is where you have to be alerted, but there is no cutoff point. As you know, the thickness will menstruating ladies will depends on the cycle, at what time you've checked your endometrial thickness. So unless there's other risk factors and suspicious features on the scan, on Dopplers on that scan, we tend not to do it as a routine thing for screening for endometrial cancer.
So
yeah.
Excuse me, Dr. Amina, I think Dr. Majid was raising his hand.
Okay, so I did not see because I'm on the chat box. So yes, Majid?
Yeah, if you allow me. Again, there is like confusion, but again, regarding the insulin resistance, as the question clearly states, diagnosis. It's not part of the diagnosis, but once, as you mentioned, the same for the lipid profile, etc. Once the patient diagnosed as polycystic, we know she's at risk of insulin resistance, etc. Then you do the investigations on annual basis. If she's pregnant, definitely has to do the GTT at earlier stage at week 20, etc. I mean, huge talk about this. One most important thing about the polycystic ovary as well, post-menopausal, again, patient as labeled as polycystic, don't forget to label them again as post-menopausal. They may have the endometrial hyperplasia or cancer at later stage. And yes, as Dr. Mona mentioned, like, you know, we don't expect endometrial ultrasound to rule out endometrial hyperplasia or malignancy. But in menopausal stage, if the thickness of the endometrium is more than 4 millimeters, then this is suspicious of endometrial hyperplasia or malignancy. So here is the rule of the ultrasound.
Thank you, Majid.
Okay, Dr. Amina, just before leaving, so
yeah.
still we have a sort of confusion regarding to the expression of polycystic ovary, polycystic ovarian disease, and polycystic ovarian syndrome. So still we have a sort of confusion, and some persons might use that or that. So can we differentiate between all of the three? Because last recommendation in the last year, I think it differentiate between just the morphology, polycystic ovary, and disease and syndrome as well. This number one. Number two, is it enough to measure the fasting insulin rather than to do HOMA test just to check resistance to insulin or not?
Right. Can I answer that? For the first question about polycystic ovarian disease, it's a very milder form of the syndrome. So the syndrome is the big thing that manifests, and that's what we see in our clinics. While the polycystic ovarian disease, it's a reversible stage where you can see a lot of immature follicles in the ovary. So the whole problem starts in the ovary without the metabolic issues that we get with the syndrome. And once we get the syndrome, we get the hyperandrogenism, we get the cycle irregularity and the morphology on the scan, and then we take 2 out of those and diagnose the syndrome, then we go with the whole spectrum of the disease. But when we say polycystic disease, we're only talking about the ovary. I don't know if that...
That's right. And what's about HOMA and fasting insulin?
Sorry, and the second question, sorry.
And what about the fasting insulin, the difference between HOMA test and fasting insulin in cases of polycystic ovarian syndrome or disease, whatever?
Yeah, so as we mentioned, if we normally rely not on the insulin, there is hyperinsulinemia, definitely for sure with the polycystic ovarian syndrome, but we rely on the oral GTT rather than the hyperinsulinemia. So we don't check.
So what's the difference between both of them? Because physiologically, the main problem, let's go back to the pathology and physiology. It's only hyperinsulinemia. So what the value actually? It use HOMA test, blood test. So I think it's fair enough to do fasting insulin, and it's fair enough if it's high, despite the fact that she's not diabetic with fasting, sugar level is normal. So it's fasting, it's high sugar, it's high insulin, hyperinsulinemia. So we can start immediately metformin, which is evidence-based rather than inositol.
Exactly, you're absolutely right. However, when it comes to real life in practice, because the hyperinsulinemia will precede the abnormal GTT. So we have a stage where we can get or diagnose the hyperinsulinemia and help the patient with a lifestyle modification before she gets into an abnormal GTT. Most of the labs, I'm talking about our experience here in Qatar, we cannot check the level of the insulin. So if you can have the insulin level in the morning, especially the morning insulin level, it will help us a lot to pick up those patients before they manifest as the abnormal GTT later. And we can help them.
It's cost effective as well. I agree with you. It's cost effective. Yes.
It is very cost effective, less time, less blood taken, and the compliance is good with the patients as well, because they don't want to stay for 3 hours to do the oral GTT. So I completely agree with you. It depends on the resources and their availability in our hospitals. But you're absolutely right.
If you allow me to add one more thing, it's about the sensitivity of the test. So insulin or insulin glucose ratio, single test, is good, but nowadays the evidence stating that it's not sometimes like sensitive enough. For that reason, you prefer to go through the oral glucose test to have more thorough assessment, or the HOMA test actually, where you get it's more expensive, more demanding, etc., to measure the insulin and the glucose every time and do the challenge test, but at the same time more accurate results. In fact, there is no perfect test. No perfect test, but it sounds like the evidence now having in favor of the glucose test rather than the insulin glucose, according to the recent guidelines.
Okay, that's fine. So you agree with me to measure the fasting insulin rather than other thing?
No, I used to do myself actually insulin glucose ratio. Nowadays, I'm relying on the glucose test. I know it is more.
So the point is, do you think there's a difference between starting medication at that time and that time? So there is no difference actually between starting, but if this, so there is no lapse of big time and complication to occur if this happen or this happen. So I think fasting, anyway, it's
I
okay.
think
my experience,
there's some, yeah.
From my experience, if you do this and you find it positive, fine. You get, the thing is you misdiagnose cases if you do insulin glucose alone. Say, sometimes it might not be enough. So the sensitivity is less. So you miss cases of insulin resistance by relying on this test alone.
I think to cut short, what we need to do is the people who have been diagnosed with polycystic ovarian syndrome, these are the people who all know are high risk of having the diabetes in later stages. So I think diet modification, irrespective of any test, you have to advise them diet modification and lifestyle changes, that's for sure. Whether you need to start them on metformin or not, I think it depends on your local lab. And as all of them suggested, that if you have got the HOMA investigation available, that's fine, go ahead. If not, then go for the OGTT, proper investigation. As we are quite behind now, it's interesting, literally discussion, and we can go on and on about it. But I think we need to be mindful of the short time. So we're going to invite our next speaker. So I'm going to invite Prof. Saad Amir, who is going to talk about the polycystic ovarian syndrome and optimizing the outcome ovulation induction. So Prof. Saad, he is working in Nottingham in UK, University of Nottingham. He's a professor in gynecology and reproductive medicine. He's also the founder and the lead of the BSGE, which is a British Society of Gynecology and Minimal Access Surgery, and accredited unit in Derby Endometriosis Center. His main research interests have largely been on the reproductive medicine, with the focus on the polycystic ovarian syndrome. And the overarching theme of his research has been to optimize and enhance the success of ovulation induction in polycystic ovarian syndrome women. He's also an editor, a reviewer, and a member of the editorial board for the major medical journals. So I'm going to invite Prof. Saad to come and talk about, again, one of the interesting topic of polycystic ovarian syndrome, which we, again, see most of the time in our clinic for ovulation induction. So thank you, Prof. Saad.
Thank you very much for the introduction. Can you all hear me?
Yes.
Yeah,
yes.
Yeah. And I would like to express my gratitude for this kind invitation and the opportunity to address such a wonderful audience. Thank you very much, Dr. Yasser, Dr. Ahmed, and Dr. Amina, and all the organizers. It gives me a great pleasure to be here with you this evening. So we'll take a different angle now in this fascinating polycystic ovarian syndrome. And we've heard quite two informative topics about diagnosis and challenges. But let's now talk about one of the major concerns women present with when they have polycystic ovarian syndrome, which is infertility. Now, infertility is very common in women with PCOS. And in fact, when we see women with anovulatory infertility, most of them, almost 80% of them, have PCOS. So let's just briefly cover infertility and PCOS and the treatment algorithm, and then look at different lines of treatment and how we can enhance the outcome and success of these lines. First and second line, there are 3 lines. Now, as you will see that in the last 15 years or so, and Dr. Ahmed Aziz has also worked with me on many of the research trials. We've been addressing this important aspect of PCOS, and we will present some of our data in this trial. So let us first, and then we talk about first line, how to maximize success, and then the second line, and so on and so forth. First line, clonophenol-letrozole. Second line, ovarian drilling or GnRH or gonadotrophin ovulation induction. So as we say, it's a very common condition. The latest figures say that about 20% of women have it, as we heard earlier. And when we see infertility patients on ovulation, 80% of them will have PCOS. So this is the algorithm. And the first thing we need to address is weight. For overweight or obese women, we have to start with weight reduction, as we'll come to, in order to maximize the success. then when it comes to first line, do we give clomiphene or letrozole? Let's look at the evidence and where we are and which one we should, and should we add metformin or not? The second line is either FSH or ovarian, which one is the better option, the more effective, and which one should we go for? And failing all these lines, then we have to resort to IVF, but this is not in the scope of this topic. So weight reduction, we all familiar with, we've heard nice talks about the insulin resistance and overweight. And in practice, and practically speaking, overweight and obesity is a sign of insulin resistance. And in routine practice, we do not need to test for insulin resistance because there are no available credible tests. And weight is usually, although some slim women may have insulin resistance, I agree. Now, we should aim for a 5 to 10% weight reduction, and that usually improves ovarian function. And some women with that 5 to 10% will get pregnant without anything. Now, should we use a cutoff BMI for any treatment of fertility? In the UK, we use 30 BMI for IVF and 35 for first and second line ovulation induction. Is this a discrimination? I think in America, they use 40 BMI. I think this is too high, and we'll see some reasons for that. And the first line lifestyle measures is the gold standard diet, hypokalemic, 500 calorie deficit, and increased physical activity, usually effective if the patient is well motivated. Second line, pharmacological, we've heard few names of the drugs, starting with obesity drugs, insulin sensitizing agents, metformin, and nowadays I use more inofolic alpha, which seems to be effective as well, and which is inositol and some folic acid, and some diabetes drugs are under research currently. Third line is bariatric surgery, which is most effective, but is reserved for those with morbid obesity who have not responded to any other line of treatment. So that covers, and it's important to get weight reduction because it improves ovarian response to any other ovulation induction treatment. Also, it reduces the risks associated with pregnancy. We don't only want to achieve a pregnancy, but we want to achieve a healthy, successful pregnancy. With high weight, we get higher risk of miscarriages and other obstetric complications. So let's bear that in mind. So first look at the first line ovulation induction. We have clomiphene citrate, which has been around for the last over 60 years. We've used it very well, and it's very effective in inducing ovulation with over 80% success. But there are some drawbacks. We need to remember that the clomiphene citrate causes anti-estrogen effects on endometrium and cervix, and hence this causes high multiple pregnancy and low pregnancy rate compared to the high ovulation rate. And there is a high miscarriage rate when we give clomiphene citrate. And the reason why we have 80% success in terms of ovulation, but only half of them achieve a pregnancy. So how can we improve this? Letrozole has been around for the last 15, 20 years, researched in early 2000s, and lately we have realized that it offers several advantages over clomiphene citrate with the possibility of higher success rate. It doesn't have anti-estrogen effects on the endometrium or the cervix, and it's a short half-life, so you don't get multiple pregnancies in theory. Let's see what the studies have shown. The first study that was published is this large American study in 2014 by Richard Lugero, which showed clearly that in those nearly over 700 patients, live birth rates in letrozole is significantly higher, from 27 compared to 19%, which is statistically significant, and pregnancy rate is 40. But again, these figures are quite low. So we can get this with clomiphene citrate, but we then realize that this trial included a high proportion of obese women. As we said, in the USA, they allow fertility treatments for up to a BMI 40. So the high proportion of this clinical trial actually had BMI around 40. And this is why their success rates for both was quite low. Then we started our trial in Europe. This is the first trial in Europe, which Dr. Ahmed Aziz has been part of it, which has been published in 2017, where we included, it was single center, but we included women which reflect the BMI, which is used in most countries and in Europe. Again, here you can see comparing letrozole nearly 160 patients, letrozole versus clomiphene citrate, with a clearly higher pregnancy rate of 61 compared to 43%, which is in line with our clinical practice. And that's a clear-cut outcome. And following this trial, and the miscarriage rate is similar between the two, and the complications are similar between the two. So we concluded clearly that that letrozole seems to be advantageous over clomiphene citrate. And shortly after this trial and a few other small trials, the guidelines said letrozole should be considered first line with a clearly cut, and the evidence is quite high that letrozole is better than clomiphene, and clomiphene should be history now, unless letrozole is not available. And looking at meta-analysis again to confirm, a meta-analysis published in 2020, I think, and this is comparing live birth rates, letrozole versus clomiphene citrate, and pregnancy. Again, the odds ratio is 1.4 for live birth and 1.45 for, so it's about 40% increase in pregnancy and live birth rate if you use letrozole versus clomiphene. So that one big advantage that we've learned how to maximize success with very simple treatment, tablets that you take for a few days. Now, how about adding metformin? There's not yet studies on metformin with letrozole. There is one currently being conducted in the UK, but adding metformin to clomiphene citrate, as we can see here, doesn't make any difference. So metformin for fertility, for ovulation induction, doesn't add much benefit to clomiphene citrate with no significant difference. And we have a large meta-analysis here to show this. Now, another way to look at improving the outcome of clomiphene citrate is to see if there's any predictive factor, is any factor that will indicate that these women are likely to respond better to clomiphene citrate. We have looked at many factors, BMI, testosterone, LH, and so many other factors, but we found, and this study again, this was the primary study by Dr. Ahmed Ez, which was published in 2013, where we found AMH level, if measured before treatment, it shows that if it is lower than 3.4 nanogram per mil, that depends on the kit you use, you have a much higher ovulation per cycle, 85%, compared to 37%, compared to 15% ovulation, and pregnancy 37% compared to 7% per cycle. Cumulative rate, you have up to nearly 100% ovulation compared to 46%, and AMH here is pregnancy 48% compared to 19%. So we think there is something that AMH can help too much. So these women with much high, again, looking at pregnant, non-pregnant, the non-pregnant ones have much higher AMH than the pregnant ones. So AMH is a recurring theme. Women with very high AMH, we need to consider their treatment. I'm talking about clomiphene, no data yet on letrozole, but do we give them higher dose of clomiphene? Do we just move to the second line straight away instead of wasting time because we know their response is quite poor? It's a question that needs to be answered by research and evidence. So this is the conclusion of first line treatment for ovulation induction. Now let's go into the second line. We have FSH, ovarian stimulation, and we have ovarian drilling. Which one should we go for and why? Again, we have done quite a few studies on this. Now, interestingly, many studies have shown that they're both equally effective second line. They both produce similar pregnancy rates and similar live birth rates. However, we have shown, and we believe that ovarian drilling offers several advantages. It induces physiological ovulation in most cases. Some cases still require the first line, as it sensitizes the ovaries to clomiphene citrate or letrozole by reducing AMH, by the way, because we know high AMH is a problem, and it reduces multiple pregnancy, no risk of ovarian abstination, and reduce LH, which may reduce miscarriage. I'm not going to go through this in any details, but this is, most of the studies have shown up to 70–80% ovulation rate. This is the clomiphene-resistant patients. So they come back from having tried clomiphene citrate with a pregnancy rate, if you allow them for a year, up to 50–70%. Few risks, of course, but it doesn't come without any disadvantages as any other treatment, as we know. There are some long-term benefits, which we have also looked at, but it's beyond the scope of this. It improves menstrual cycles, it improves skin, improves long-term risks as well. Okay, and this is the meta-analysis again, published in 2020, which have shown that both ovarian drilling and FSH are equal in terms of live birth rate. These are 2 RCTs published, there are not that many. But when it comes to multiple pregnancy, as we expect, it's much lower when you talk about ovarian drilling compared to FSH. So it's lower multiple pregnancy, similar live birth rates. So we have seen, but ovarian drilling, despite all these advantages, it comes with some drawbacks. Firstly, it requires general anesthetic, and it's an invasive procedure. And there are risks associated with laparoscopy, as we know. These risks can sometimes be quite high. Also, when you drill the ovaries, laparoscopically, those who are familiar with the procedure, you end up with charring of the surface, and that can cause adhesions, and this can contribute to infertility and can cause pain. And when we used to do this procedure, it's a crude instrument. It's not specially designed for this procedure. So there's no standardization. It's just an empirical procedure that we do with some risks. So for this reason, we started over the last 7–8 years, we started to develop another approach to doing the same procedure, ablation, through a transvaginal approach. There have been several attempts, but what I'll go through, so instead of doing what I've just shown now, we now are able to do the same thing through a transvaginal approach, an office procedure, minimal invasive, with much reduced risks and no need for general anesthetics. So let's discover a little bit more about this. We are using the same transvaginal probe used for IVF, so it's not a completely new technique. So we use the same needle, and through that needle, we will introduce an electrode that goes into the ovary, small, very tiny, under visualization of ultrasound scan, doesn't cause any charring on the surface, as we can see here, and you can deliver a precise, calculated amount of energy to give you the required amount of ablation, which is between 5 and 10% of the ovary. That's all you need to do. So there's more sophisticated work and technology to be achieved here. And this is what is done to introduce this and put it through the vagina. Now, it's no general anesthetic, no laparoscopy required. It's an office-based, purpose-designed device, similar ovarian access to oocyte retrieval. So it's something that comes with wealth of experience. We can calculate exactly what we deliver and no surface damage to the ovary. Again, the generator is very simple, and you adjust your temperature and your timing and your wattage of electricity to deliver what you need. This is gone through preclinical ex vivo studies using bovine ovaries to do the ablation through a transvaginal approach, and take it out, cut it, chop it, and see how much ablation happens in the ovary, and replicate this in cows. So we've done some work on the cows to transvaginal. Apparently, I've been to this farm in France where they do egg retrieval for cows for assisted reproduction technology. So we applied the same technology on cows before moving on to human. Again, you can see here, we're doing the same procedure before moving on to human. Okay. And until when we've done the preclinical ex vivo, we went into the actual clinical trial, phase 1 trial, feasibility, safety, efficacy. So we have just finished the multi-center international USA and Europe in 7 sites, where we've done in UK, France, Belgium, and USA. and we have completed, and this is just a cohort of the patients. We recruited 18 to 40 clomiphene or letrozole resistant with BMI under 35. In America, it was 40, as we know. And these are the criteria that we need: patent tube and accessibility to the procedure. This is the follow-up algorithm. Okay, and this is the procedure, exactly the same as picking up eggs. Okay, now the beauty is you introduce the needle and you see it under the scope. You only introduce the active electrode when you can see the needle inside the ovary and away from the capsule, away from any bowel or any structure. Okay, and you calculate, the system will calculate the number of ablations you need to do. You put it, do the send the electrode, deliver the energy, pull it back and put it in a different area to do similar thing. And in the first few cases, we've done laparoscopy to see what we're doing. Minimal bleeding inside and the ovary. You can't see any charring on the surface of the ovary here at all. Some blood loss, but nothing really. So follow up to 2 years. Initially a week, 30 days, 12 weeks. We've done scans, we've measured AMH, and we've measured all hormones after surgery. And this is just brief result of the study. We can see here that ovulation rate in the first 3 months without anything. These women have been trying for years, and we get 44% of them ovulating after the procedure. If we add clomiphene or letrozole after surgery, it goes up to about 2/3 of patients start ovulating very well. And so far, we're still collecting data. Patients are still being followed up. But so far, we had almost 1/3 of them pregnant, those who have failed other treatment options. So we can see now we are starting phase 2, which is a larger trial to to validate the evidence that we have generated. And it has shown to be feasible practically. We've done almost 100% of patients who were suitable for the trial had the ablation, most of them in 2 ovaries. Very few, about 10% had 1 ovary. And all minor, there were some complications from the laparoscopy, but nothing from the actual procedure. Now, another thing to improve the outcome of ovarian gelling is, again, like we did with clomiphene citrate, to look at the AMH. AMH seems to be a very important predictor. And this is why I strongly recommend AMH before any treatment, because the ones with very high levels of AMH are much less likely to respond to treatment. And we have recognized 7.7. As you can see, this is higher in ovarian gelling than clomiphene citrate. And for this group, maybe they should not offer, they're not likely to respond to clomiphene, to ovarian gelling. Okay, so the ones less than 7.7, they have a good success rate in terms of ovulation, almost 95%, a good pregnancy rate compared to those with lower AMH, and this is significant for ovulation at least. Obviously, the numbers are small here. And then the last thing I'll talk about is, again, this is a study that Dr. Ahmed Izz has been involved with. He has actually conducted himself, looking at AMH with FSH. Again, when you use AMH, you see that AMH below 4.7 gives you a good sensitivity to pick up patients who will respond well to FSH. Lower than this, higher than this, they are less likely to favor it. So good response, ovulation, 100% if they are lower, okay, and 74% if they're higher ovulation rate, and that seems to be significant in terms of outcome. Again, higher than 4.7% AMH is not a great. They might need higher dose or just move for IVF. That concludes my talk. Thank you very much for good listening. It's a big topic. We can go on for hours and hours, but I appreciate the time is limited. And this is my nice team at Royal Derby Hospital, our research team that has been working hard. And Ahmed obviously was part of this a few years ago, but when we took this picture, he wasn't there. Thank you very much. Any questions?
Thank you so much, Prof. And I'm sure there are quite a few questions. Dr. Ahmed is going to take through the questions. Thank you, Ahmed.
Thank you. Thank you very much, Dr. Saad, for this fantastic talk as usual. And thank you for shedding the light over the work I have done under your kind supervision. And actually, your work on aromatase inhibitors has changed the practice and the guidelines thanks to your dedication and the meticulous work. We have many questions actually. We can start with the questions about the cutoff level of MH. Do you think is logic for diagnosing polycystic ovarian syndrome in adults?
So going back to diagnosis, I enjoyed the talk by Dr. Majid, very interesting. And as I agree with him, he can't really give any, for several reasons, you can't really give any cutoff. The first and most challenging reason is they enter, let's say, variations between kits. Every lab has a different kit level. There's no, as far as I know, there's no cutoff that has been agreed to diagnose AMH. I don't use it for diagnosis, to make it clear, but I use it to guide treatment as a predictor of success. When we looked at AMH for the ablation, it's the same thing. Higher AMH stops ovary response. We know that AMH inhibits follicle response to FSH. So this is why they don't respond very well. And by doing the ablation, you actually reduce AMH, and therefore they're likely. But I don't use it for cutoff for diagnosis. Thank you.
And do you use it for stratifying patients for different lines of treatment? So, for example, patients with very high MH can go directly for laparoscopic drilling or gonadotropins rather than losing time in trying with clomiphene citrate and aromatase inhibitors?
Common sense says if the MH is too high, what I do, because there's no guideline yet and no clear evidence on this yet, we're trying to get this into the guidelines. But what I do to patients, because to be honest with them, I say, if your AMH is so high, it's likely that your response will not be great. So maybe we could, because we just follow the evidence base, I wouldn't waste too much time with clomiphene or letrozole, maybe try a few cycles. Now, if the AMH is not too high, we can try longer, maybe up to 6 cycles. But if the AMH is, I give them the option, I discuss the factor, and then if they want to try the clomiphene or letrozole, I give them short cycles and then move on to either to second line or ovarian drilling to reduce AMH.
Another question is that, is there any data comparing the outcome for transvaginal needle versus laparoscopic ovarian drilling in the hormonal profile and pregnancy outcome in patients with PCOS?
As I said, there have been multiple attempts at doing transvaginal procedures, but none of these have really culminated into any standardized practice. The only one that is now nearly into the second phase 2 trial, multi-center trial, will be the new May Health device ablation. But this is early phase. We only had preliminary data. We're waiting for the big study. And at that point, maybe we can look at comparing laparoscopic versus ablation. But probably not a good idea, because we have seen over the last 10 years that ovarian drilling anyway has gone down in practice, simply because of the associated risks and the need for general anesthesia, and the alternative approaches of FSH injections, which are equally effective. So why should we subject someone? So in reality, it has gone down. 20 years ago, there was a surge of ovarian drilling. Everyone was doing ovarian drilling. But 10 years ago, there was a study in Australia which has shown clearly that there has been a lack of interest, probably because of the risks and general anesthetic and so on and so forth. I don't see this happening, comparing ovarian drilling with transvaginal ablation. It doesn't make sense because it's obvious. They both do the same, and you don't want to ethically subject patients to general anesthetic and risks why it's not necessary.
Okay. One of our audiences, Dr. Sharif Suleiman, is surprised about the combination for drilling with the laparoscopically or vaginally. Also, the fact that trying to do it vaginally without anesthesia seems to be hard to work in fertility. And he's asking also about the long-term effect in terms of AMH reduction, menopausal age, etc.
Very good question. And we have published several studies on the effect of ovarian gelling, and we've looked at the effect of ablation on AMH. The misunderstanding here, and we get this question very often, is that the reduction in AMH is not actually a damage of ovarian reserve. It's rather normalization of AMH. And we have done several, and we and other groups have done several long-term studies, and there is no evidence, there's no evidence of any ovarian reserve damage after up to 10 years after ovarian gelling. If it is done according to the rules that we have set up, the amount of ablation, 5 to 10% ablation of the ovary, doesn't damage in the long-term ovarian reserve. If anything, these patients get better with time, and their cycles get regular, and AMH becomes normal afterwards. I hope this answered the question.
So do you think, Professor Saad, that the number of dwells and the energy should be customized according to the ovarian size and the AMH level?
Yes, absolutely. We currently use the ovarian volume, and ovarian volume we calculate because we need to achieve a minimum of 5% ablation. If you do much less, 2-3% ablation, you may not get the same benefit, and we have evidence for this. So to calculate this, you need to measure. On the day of the procedure, we do the scan, measure the volume, calculate, and the machine is automatic. It tells you need to do this ablations to achieve a minimum of 5% ablation of ovarian tissue. So yes, ovarian volume. We've not yet considered the AMH. We just wanted to keep it simple, and AMH correlates with volume anyway. So the higher the volume, the higher AMH in most of the studies.
We have another question about the role of inositol in these patients, in the infertile patients with PCO.
The role of letrozole.
Inositol.
Inositol.
Yes.
Very good question. Now, again, as been mentioned earlier, inositol, there's something now called enofolic alpha, which has inositol, the two components of inositol in a specific ratio. There's several studies from America talking to the two types of inositol. For me, I think it's, I discuss with patients the metformin, which has been extensively studied, and I've seen some guidelines for using it in women with possible insulin resistance. And also, I offer them enofolic alpha instead of metformin, which they can also try. Both of them, they don't work for everyone. It's a case of trial. It's experimental for all women, especially for overweight, obese women with some signs of insulin resistance. I don't think we need to measure insulin resistance for these women simply because there's no valid clinical test to do. And as Professor Yasser said earlier, if a test doesn't change your management, you don't need to do it. And when we used to do a lot of studies on PCOS, we've learned that we only do the insulin resistance clamp test and HOMA test. It's experimental. It's for research. It's not for clinical practice. I'm not aware, and I've spoken to my diabetes colleagues, that there is a straightforward practical test in clinical practice to measure insulin resistance. Obesity is a good test. A few other things in terms of the type of obesity, waist to hip ratio, and so on and so forth, and visceral obesity. They are very, very sensitive in terms of expecting insulin resistance. And at the end of the day, whether or not they have insulin resistance, you can try metformin or inositol or enofolic alpha, and I ask them to try it for 3 months. I think from clinical practice, 50% of them will feel the difference. Their cycles get better, their skin get better, and some of them even ovulate normally. But for some women, it doesn't do anything. Recommendations, as far as I remember, is for women with impaired glucose tolerance tests. So some women suspected for, because we need to, as mentioned earlier, we need to test for possibility of risk for diabetes. And this is where you need to do the glucose tolerance test, not for diagnosing insulin resistance, but for this obese women with PCOS, you need to rule out diabetes or risk of diabetes.
Thank you very much, Professor Saad. I think Professor Yasser Abu Talib is raising hand. I think he has a question for you.
Okay, so Dr. Thank you very much for your wonderful presentation and excellent knowledge. But I would like to ask you regarding to the amount of energy that will
Sorry, the line is broken a little bit.
Through the outpatient clinic.
Sorry, the line is broken.
I
can't.
How can you calculate it? I'm sorry. Regarding to, can you hear me now, Dr. Saad?
It's a bit better, yes.
Okay, that's fine. So first of all, I would like to thank you very much for your wonderful presentation and huge amount of new knowledge. Thank you very much. However, I would like to ask about the amount of or the volume or the amount of energy that we have to adjust the machine. How can you calculate it? Because I remember well that I attend one of the lecture, maybe. So are you using this calculation, or do you have your own calculation for the energy production?
That's a very good question. It's very simple. We don't do it because the machine does it for us, but it's very simple. We say we need to burn 5% of an ovarian volume. So we measure the ovarian volume and do 5% of it, and that will tell us you need to each ablation will give you a certain volume of ablation. Then we just count a number of ablations to deliver the number of volume. You don't need to, as a clinician, I need to understand the system, but the machine measures the volume and says you need 5% ablation of this volume, and 5% ablation is 6 ablations, 7 ablations, or whatever. As it stands, we go up to 10 ablations because first.
Okay, so it's machinery calculation, not human type.
Yes, yeah.
So it's machinery.
You can calculate it if you want, but it's not that difficult.
Okay, thank you very much.
I think we are going to come towards the closing of the seminar. So Ahmed, we are gone already quite behind the time. So can you do the closing? And
I think Professor Shiv Abdel Fattah wants to give a word.
Thank you very much, everyone. Just a quick word really to thank everyone. Really, the MENA region is setting an example of cooperation and running very high-value scientific webinars and scientific activities, and also combined activities. So just to thank all the speakers, thank the moderators, thank the chairs of the IRCs in Egypt, Saudi, and Qatar, Professor Yasser, Dr. Amina, Dr. Osman, all the speakers, really very, very high quality speaking, very well organized meeting. Thank you, Dr. May, for the organization and for all the attendees, because these webinars will not be successful without good attendance. So really thank you for all those who attended and for the very, very fruitful discussion, the questions and answers. It was very useful. And I would just like to say that the MENA region is setting an example for other regions about the productivity and the cooperation between countries. So really just a quick word to say thank you very much and keep it going.
Hi, Sharif, I think you wanted to bring the attention for the Congress as well in the end.
Exactly.
So
I would like just to remind everyone of the Congress, the ERC-RCOG World Congress that's taking place in Oman, 15th to 17th October, and there are pre-Congress workshops, very, very high quality workshops. There are, I think, 8 workshops, and we would like to have good attendance from the MENA region. We have almost half the speakers are coming from the MENA region, so the region is very well represented speakers-wise, very high quality speakers, and would like good attendance. There have been good submission of abstracts also from the region, but we would like to have good attendance. Just it's no secret that bidding for future congresses depend mainly on how much interest in the region is. So Oman, even though there are no representative committee of the college there, they have made a very good job, which is encouraging and stimulating other countries from the region to apply for future congresses. But as I said, one of the factors is how much interest and enthusiasm. So we need really good attendance. So please still look into registration if you haven't done so, and looking forward to see you all in Oman. Thank you.
Thank you, Professor Sharif. And thank you very much for all our prestigious speakers and respected audiences in this wonderful scientific meeting. And we wait for all of you in our next webinar that will be announced shortly about endometriosis. Thank you very much.
Thank you, everyone, for wonderful work. I'll see you shortly again. Thanks, everyone, and thanks to all attendees.
Thank you very much. Thank you.
Bye.